Wati. So good morning, my relatives. I come to you with an open heart and hands. My name is Cami Goldhammer. I am Sisseton Wahpeton, and I am coming to you from the occupied land of the Duwamish people, also known as Seattle, Washington. So I'm very happy to be here. And excited to talk to you all over the next, well, we'll see. In general, I'm not very good at ending things on time. So it's kind of like once I'm told I need to stop is when we'll stop. So I'll just talk as long as I can. And hopefully we'll have some time at the end for questions as well. But I'm really grateful. Thank you, Maddie, and the rest of the National NIHB for your invitation to speak today. I really appreciate it. And hopefully this will go well. So I was asked to speak a little bit about today about the role of or lifting the voices of moms and birthing people and pregnant people in the AIAN community. And so I'm going to share a little bit about that as we get a little deeper into this presentation. But I kind of decided to frame this around the role of Indigenous doulas and kind of how we work, and particularly in my organization, how we work in really like lifting the voices of our community members. So hopefully this is sufficient. So again, my name is Cami. I'm very grateful to be here. I am home alone with my bougie res dog Memphis, who's right down here. And so she, hopefully she doesn't make any noise or I don't have to get up and take care of her, but I'm on my own, so I might have to. No one else can let her out. But yeah, so I'm a clinical social worker, licensed clinical social worker, and a lactation consultant, so internationally board certified lactation consultant, and a full spectrum Indigenous doula. I do a lot of work throughout Indian country when it comes to maternal child health, largely around breastfeeding, rematriation, and the reclamation of our birth and breastfeeding practices. So I'm not going to spend a lot of time talking about Indigenous breastfeeding counselor, but that's one of the roles that I do in the community that's not necessarily associated with this, but just did want to give a shout out to that work. And I know there's a lot of Indigenous breastfeeding counselors on this call. I did a quick zoom through the names. So Indigenous breastfeeding counselor is a 5-day foundational education training, breastfeeding education training that myself and my best friend, Kimberly Morsalis, who's a Navajo lactation consultant, her and I travel throughout Indian country, really just kind of giving back the information that belongs in our community so that you all can do the work of serving your community and providing lactation support. But my day job, my job here at home in Seattle is I'm the executive director of Hummingbird Indigenous Family Services. We have 2 programs. One is Hummingbird Indigenous Doulas, which I'm going to spend a fair amount of time talking about. The other is what we're calling Hummingbird Nest, which is a pilot project that we'll be launching at the end of summer, which is a guaranteed basic income program, which will provide Native birthing people with a guaranteed income of anywhere from $1,000 to $1,500 a month from the time of pregnancy until their child's 3rd birthday. This is going to be no strings attached dollars, and it's funded by a funder named Perigi, which is an amazing billionaire wife. So anyhow, we're really grateful about that work and can't wait to talk more about that. But it's relevant to share that information because one of the outcomes that we have from that guaranteed basic income program is that it will prevent maternal mortality, that by putting, and infant mortality, by putting cash in hands of families, straight up, no strings attached dollars, that will allow them to relieve some of the stresses that they experience, pay for different things. We expect better health outcomes, all of that kind of stuff. So someday maybe I'll present on that. So with that, I'm going to go right ahead. Okay, cool. So just so everyone's kind of aware kind of what I'm going to be talking about is I'm going to frame us up with a little bit of information on Washington State, which is where I'm located. We'll kind of go over some of our statistics here and define some words so we're all on the same page. I know that most of you have been in this conference now for, you just started day 2. And so I don't want to be too repetitive at all, but I also want to make sure that we're just on the same page so that what I'm discussing makes a little bit more sense and that there's context for, for that. And then we're going to talk about doulas and what we do, and then we'll talk about our program. All right. So the first thing that I wanted to discuss was just to, again, give a little context for the work that I do here in Washington, particularly in the urban community of King County, which is the county that Seattle lives in. So Seattle and the surrounding suburbs. This is from our maternal mortality annual report that was released in 2019, and it looked at the deaths of pregnant people and postpartum people from 2014 to 2016. So it was a pretty in-depth report on those couple of years. We have our maternal pregnancy-associated deaths and pregnancy-related deaths, and I'll define those in a second. But the main thing, and I'm sure that you all can see, is that I wanted to point out is the massive disparities that we are experiencing in Washington State, and particularly how American Indian Alaska Native pregnant and birthing people are overwhelmingly dying. So at much higher rates than other communities. And I think that this is really important to point out because I'm sure that many of you, and you may have talked about this already in the last day and a half, but understand and that concept of data genocide, right? Or death by invisibility and what happens. And that's definitely one of the things that those of us that work in the maternal mortality, infant mortality, advocacy world or prevention world really struggle with our community, the American Indian Alaska Native community, being visible in this, right? If and this is not meant to at all like get into like an oppression Olympics with any other group or minimizing the deaths. None of these deaths are reasonable, right? Even like outside of the Native community, none of them are okay. And as long as any moms are dying, then we need to be doing something about it. And at the same time, if we talk to most folks, just off the street and ask them who has the highest maternal mortality rates in the country, or if we just did Washington State specifically, American Indian Alaska Native people would not be named in that group, right? Unless there's some inside knowledge there. And as you can see here in Washington State, when it comes to pregnancy associated deaths, that we are dying at nearly twice the rate of Black moms in our state, almost 3 times the rate of, or sorry, I think I said that wrong, but anyway, it's about 4.5 times the rate of Black moms in Washington State. Anyhow, it's just something that we really need to address. And when I first saw this report, when it came out, I was immediately kind of like, why are we not talking about this? Like, why is this not something that was on the news? Why, it was just really, really frustrating to kind of recognize that, again, like that our community was invisible in a lot of these statistics. Oftentimes we're statistically insignificant. We're moved into the multiracial group, which I still have questions about that here. But again, I just want to make sure that everyone's kind of on the same page of where I'm coming from, because this report had a huge impact on the work that I do and the funding that I receive to be able to do that work here locally, which was to address maternal mortality. So when, again, just to kind of define these words, the terms that are being used, so pregnancy-associated death, this is a death of a person, and I will say I took the liberty to change the word to person in the maternal mortality report, and the word that the DOH uses is woman, but I changed it to person to be, again, inclusive of our two-spirit relatives, our non-binary relatives who do not identify as women per se, but are birthing people and are pregnant people. And so I did change that word, just so you all know about that. I want to be transparent about that change. So it says the death of a person during pregnancy or within a year of the end of pregnancy. So in pregnancy-associated deaths, that includes pregnancy-related deaths, which I'll define in a second. It also includes deaths that are deemed not related to pregnancy. So this could be a car accident, right? That someone is driving and they get in a car accident and that person died and they happen to be 7 months postpartum, right? Like that hadn't, they determined that it had nothing to do with the pregnancy, but it still is kind of grouped into this pregnancy-associated death. And I will say that pregnancy-associated death does tend to be the number that that is used in public health. So that's something that's important, at least here in Washington State it is. And then we have included in pregnancy-associated deaths is also deaths that they cannot determine if it was pregnancy-related or not. I don't have a good example of what that would be, but it could be, well, maybe one good example would be a person who maybe is experiencing a perinatal mood disorder and causes a car accident to die. Right, or something like that, or so that would be something that there might be hunches, there might be some evidence to suggest that it was related to a perinatal mood disorder, but they also can't say it is, and so that kind of falls in another bucket there. Yeah, so that's what's there. And then we have our pregnancy-related deaths, and this is a death of a person during pregnancy or within 1 year of the end of their pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiological effects of a pregnancy. So those are two definitions that we're kind of working with when we're talking about this. Okay, so some key findings, and again, this is important because this played a big role in my organization and our doula program getting funded, is some key findings that came out of this report was one, that most deaths were preventable. So the Maternal Mortality Review Board, which is a board of community members, professionals, medical providers, public health folks that review the deaths of women and people who died of pregnancy-related causes. There tends to be different mortality review boards that occur within most public health departments of health. So I happen to sit on the Infant Mortality Review Board for King County. And so we review, my group specifically reviews deaths that are considered to be SUID, so sudden unexplained infant deaths. So that's what we do. So we're a group of professionals that kind of go through and look at the case, read the medical report, the police reports, all of that, and kind of make a determination of what the cause was. So most deaths were preventable, and that was 60% of pregnancy-related deaths were considered to be preventable, okay? Most pregnancy-related deaths occurred in the postpartum period. So 30% occurred during pregnancy or delivery. Apologize for that. I forgot the Y at the end of delivery, but 35% occurred within the last, within 42 days of the delivery of the baby. And I'm going to come back to this in a minute, but I just want to point out that in many of our traditional cultures across the world, that sorry, I have text messages coming through on my computer. Let me turn my Wi-Fi off on my phone, so hopefully that prevents that from happening. Most communities, Indigenous communities around the world, consider the postpartum, including many of our Indigenous communities here on Turtle Island. They're still going to come through, so I just apologize for these dinging, but we tend to have, you know, a postpartum ceremony or a time period, a sacred time period after a baby is born. And pretty much universally, the length of that time period of that postpartum ceremony is 40 days, right? So I think that is so important to point out. And when we talk about the, you know, Indigenous ways of knowing and that kind of idea of like, we just know these things, right? And then later on science confirms, or researchers confirm, or white people confirm that it was true, you know, when we've been doing it since the beginning of time, right? And so I think that this is a really powerful statistic here, of something that, again, confirming something that we've always known, that this was a vulnerable time and a sacred time, and a time where our community was responsible for taking care of people in this time period, because it is vulnerable, right? It's a vulnerable time period. So we've always known that. And again, this statistic confirms that. Most deaths were a result of behavioral health conditions. So about 30% of deaths were related to, were a result of suicide or overdose. And so that is also something that I really want to point out. And so when we think about who is responsible for preventing the deaths of people postpartum, right? When I see this information, what I see is that this is a failing of a community of healthcare providers. This is a result of colonialism and racism, right? That our world no longer allows us to care for people in the postpartum period and during their pregnancy and the way that they are supposed to be, right? We still have these Stone Age bodies. And this is something that I feel really strongly about, that it is not the fault of Native women for dying after they have their baby, right? We are perfect. We are perfect, sacred beings. And that the things that put us at risk is not that a result of us being Native, right? Like, that's not what it is. It's the result of colonialism and racism and weathering over the last 500 years that have really put us at risk. And then when we look at the postpartum period and the increase of maternal deaths that we see in that time period, that falls on us, the ones that are caring for these families, right? Like in the community and the people that are seeing them, or in most cases not seeing them, right? And I always say it, like, it's very concerning to me that kind of, again, looking at this 42 days postpartum, that after a person gives birth, most of them are not going to be seen by their provider until 6 weeks after they have their baby, right? Which is about 45 days postpartum. Okay, so these are things that we really need to address, of like, how is the maternal health system supporting families, and is the way that they are doing things advantageous to our community, right? And I would argue that it is not. And it is a massive failing, and it's a disgrace. So thinking about then, if we're kind of saying, and let me back up a little bit. So when when I had the opportunity to kind of write a grant for a doula program, well, at the time it wasn't really a doula program, but a community design program to address maternal mortality in our area, right? That was kind of what the RFP was put out for. So a community design program, meaning it did not have to be, quote, evidence-based. It did not have to be, quote, a best practice, because we know and have seen time and time again how evidence-based and best practice programs or curriculums continually fail in Native communities, right? Like they just very often don't work. And so this was an opportunity to design a program. And so we started that design process with a community advisory board and community listening sessions, right? And I'm just about to embark on a whole other round of statewide listening sessions for Washington State, but this time it was just King County specifically. So again, King County is the county that houses Seattle and the surrounding suburbs. And so we started out again with the community advisory board and holding community listening sessions to talk to our community, to our birthing people, our pregnant people, about what their experiences were like during their pregnancy and after having a baby. What were the things that they needed? What were the things that they wanted? What were the things that worked well, right? What were the things that were supportive and helpful? And there was a lot of information that came out of those community listening sessions, but overwhelmingly what they wanted was doulas and access to doulas. There was also some, advocacy for access to midwifery and midwifery care, and also out of hospital births, which our community is a very small percentage of folks that choose to deliver out of hospital. And so, getting more information and things to people about other birthing facilities or birthing options was really important to people as well. But again, doulas and access to Indigenous doulas was really, really, really important. And so that's what I kind of decided to move forward with a community design program. The other thing that we got when we were kind of looking at, again, this is kind of the part of lifting up the voices of Native pregnant and birthing people, is that mainstream doulas, like the mainstream doula world, didn't really work for them. So for folks that aren't familiar with a typical kind of mainstream, quote, mainstream doula, that would be, they typically do like what's called a 2-1-2 model. So that means 2 prenatal visits, 1 birth, 2 postpartum visits, and then they're done. They're done working with the families. And our community was saying overwhelmingly that that is not what would work for us. That is far too little time. We have an incredible doula organization here in Washington State called Open Arms Perinatal Services, which is one of the oldest and maybe even one of the first community-based doula orgs, formalized community-based doula orgs in the country. They serve a wide variety of people, so really diverse populations. But they have a community, a program called Outreach Doulas, and they serve families for pregnancy, birth, and then 2 years postpartum, and kind of move into a home visitor role in those 2 years postpartum. And so we also had community members saying like that felt too long, right? Like we kind of needed something in between. And they also really didn't want a curriculum or any finite visit policies around how many visits they should have to do. They really wanted something to be like family centered and unique for each individual family to create with their doula. And so that's how we decided to move forward with creating a doula program. I was very passionate about us being a full spectrum doula program. It wasn't a huge priority of the community, and I don't want to say like that I made a decision. It just, and I'm sure a lot of you have had this experience where I definitely have, being a breastfeeding advocate, where I can like talk about how important breastfeeding is, but a lot of times they're kind of like, the community might just be like, yeah, we're trying to to work on our 60% diabetes rates right now, or we're trying to work on, our suicide rates with our youth right now. Like, you want to talk to us about breastfeeding, why, right? Like, it just tends to be kind of low priority when there's these perceived, actually perceived isn't the right word, crises that are taking more priority over those things, right? And so so a lot of our community members, when we were talking to them, they were like, we just want doulas. They weren't necessarily like, I would like a full spectrum Indigenous doula. They're like, we just want Native doulas. That's all, that's kind of what it is. And so thinking about and kind of defining what a doula, an Indigenous full spectrum doula is, in short, we're an auntie, right? So we're an auntie. In Dakota, the word for doula is the same word as doing, the same word we use for auntie. So, a lot of times I'll tell my families when we're doing our intakes, I'll say things like, we really fulfill the traditional role of the auntie within a family. Think about what your aunties would do for you postpartum, if you lived closer, if they were healthier, if you had a better relationship with them, if they were alive. Right? A lot of our families are impacted by premature death of our adults, and so they don't have access to their aunties in that way. There's all sorts of different reasons why the family may not be able to do this, fulfill this role within for the birthing person. And so that's kind of what we do. And I describe each doula as a different kind of auntie, so I have, I got Vanessa, who's like your mom's oldest sister. She's the one that just knows what to say. She brings all the calmness to you. You go to her with everything and she always has an answer, right? And then we have Cassandra, who's the auntie that, like, you were wrong, then she's going to be like, earrings out, like, who we going, like, let's do this, right? Like, who do we know need to go beat up? I mean, that's we just have, like, each doula really embodies a different type of auntie within the community, which is really awesome. But really what we do is we provide continuous emotional, spiritual, physical, and mental support throughout the perinatal period. And this is really important, kind of thinking about perinatal period and the definition of full spectrum. So this means that we support people who may not be parenting at the end of their pregnancy. So we support people who are experiencing pregnancy loss, that are, we have 3 families right now that are on their trying to conceive journey. They've been experiencing fertility challenges. And so we're, doing support for them. We are an organization that is pro-abortion, and we support our Indigenous families in accessing abortion, and we provide doula support for them to access to receive an abortion, and we take care of them postpartum the same way we would take care of someone who delivered a baby and is choosing to parent. And that's just with love and compassion. Usually we're only working with our family abortion clients for maybe a weekend, after they have their abortion, like a couple days versus a couple months, the way our families who are choosing to parent we might work with. But it's just really important to us that all pregnant people receive the care they need, regardless of the outcome of their pregnancy. But most of our families, an overwhelming majority of our families, do come to us for perinatal, birth, and postpartum support, right? So that's what most of our families are coming to us for. I just wanted to introduce you to our doulas. So I have a team of 4 doulas. There's myself, which I still go to births. I just can't help it. Like, despite being an executive director and doing a whole bunch of other stuff, I attended a birth a couple weeks ago. But overall, like, the doulas on the team do most everything. I do try and do a lactation visit with every family a couple days postpartum. So I check on breastfeeding, make sure all of that's going okay. But my doulas are Vanessa, and we do serve the Native Hawaiian and Pacific Islander community as well, even though about 85% of our families are Native American, Alaska Native, and then the rest are Native Hawaiian, Pacific Islander. So we have Vanessa, Cassandra, Kristen, who is actually currently a doula client of ours. So she's a couple months postpartum, had her baby in December. So she's had a bit of a role reversal, going from being a doula to being a doula client. And then we have Tier. So really, really incredible team. And we're hoping to grow our team even more in the future. So here's just kind of looking at the things that we do. And this all came out of kind of our advocacy and the work that and what our community told us they wanted. So you have, I don't know if you all can see my cursor. Are you able to see my cursor when I move it on the screen? Oh, you are. Okay, cool. Okay, so here's just a picture of me at a birth during Rock Your Mocks week. So I was wearing my moccasins at the birth and had to take a picture of that. Here's Vanessa getting preparing some moringa, which is a galactagogue or a milk making herb. That's one of our favorites. It's a Thai spinach, so it's a great milk maker. And so Vanessa is one of our like resident yummy cooks on the team. And so she cooks with the moringa, and then she uses the stems to make a tea, which is a milk maker, so a milk booster. Here is a really awesome picture of three of us doulas. So the three of us are here, and then Mama Elena is here, and baby was due really soon, and their cradle board wasn't finished, and so we spent a couple of days with her finishing up her cradle board, or working on a cradle board with her. I brought it home for a week to beat it, and then she was able to finish it up before baby was born. But it's just a great example of what an Indigenous doula does versus like a mainstream doula, right? Like a lot of mainstream doulas would not necessarily see that as an important part of their role. But for us, it was really important because we knew that this baby couldn't come until that cradle board was finished, right? That was really important for the family. And so we were really happy to help out with that. Here's Vanessa preparing a cedar bath for a family postpartum. So we do offer some ceremony for our families. We find that for a lot of our families postpartum, that come to us, a lot of them, they just want an Indigenous doula. They don't really have any expectations beyond that. But for a lot of people, and I would gather most families, when they get pregnant, for them, that's a new opportunity, right? That's an open door to try new things and to maybe reclaim things that were theirs, that have been dormant, maybe in their bodies or their systems for a long time. And so we have a couple of ceremonies that we've been given permission or gifted to do, and the cedar bath ceremony is one of those. And so we do cedar bath ceremonies with most families after they have their baby, if they want. Most do want it. And what's really cool too about our cedar bath ceremony is that even our PI and Native Hawaiian families really like to partake in it because they're here in Duwamish land. And so they feel really, even though, cedar doesn't necessarily grow in Hawaii, and that's not a ceremony that they have there, but this is where they call home. And so it helps them to feel connected to the land and to the Indigenous people that are here. So they're usually really happy to partake in that. Here's just a picture of me. You can see I have baby in a carrier, right? So I'm carrying the baby and then cooking dinner for the family. So it's a lot of just that postpartum support. We also do cradle board classes in partnership with NADAM, which is the Native American Women's Dialogue on Infant Mortality, where we do a one-day workshop, and at the end of it, each family goes home with a cradle board that they made for their baby. So this is part of a series that I kind of call it like a birth bundle series, where each month the families can create something for their baby bundle, so or their birth bundle. So we have cradle boards. We did a birth gown making class where they made basically birth gowns, like hospital gowns, but are ribbon skirts. So ribbon dresses. So we did that. We're going to be doing a star quilt class soon. So just, doing different things for that baby bundle. Here's what we do a lot too. We do a lot of hip squeezing. These are, just different practices to help a birthing person get through labor and delivery. We have lots of tips and tricks and tools for pain management and things like that. So we do a lot of hip squeezing. And then we do a lot of cooking. So we really feel strongly, and this is something that our families really wanted to, again, when we asked community what they wanted, some food and eating traditional foods after they have their baby is really important. And so these are just some of the different things that, most of these are things that I cook. This is Vanessa cooking something for one of her families, but the rest of these pictures are things that I do. And so this is just like a blood builder that we do for families postpartum or post pregnancy loss, to just, kind of rebuild the blood and those iron stores for the family so they can recover quicker. This is just like a wild rice. So a lot of you may have had this. It's just wild rice with cranberries, and then we add blueberry and cinnamon and syrup, just a super yummy postpartum meal that can be eaten as like a dessert, breakfast, whatever, a snack, whatever. So we make that. This is a salmon chowder that we make, salad, cedar tea. So I make a lot of cedar tea. I'm really lucky to live in, I live in Seattle in an urban area, but I'm also just a few blocks from an old growth forest park here. And so I'm really lucky to be able to harvest cedar a couple times a month and make cedar tea for our families. We also do, in the times of COVID, have been supporting as our families come down with COVID, which is at this point just inevitable for them. We make sure everyone has cedar tea to get through their illness, things like that. We also do different community events. So this picture in the upper left picture is actually from our doula training. So, one of the things that the community had asked for, or birthing people had asked for, was more Indigenous doulas. And we knew we were going to be creating this program. And I was missing one thing though, and that was Indigenous doulas. And so, and what I did is had my dear friends, Melissa and Candace from Winnipeg, who run, are the creators, and they run Zagidewin. I have to plug in my computer, but Zagidewin doula training. And so they came down and did that for us. Okay. And so I hired from this group of doulas that were trained, but then we also supported or encouraged them to create their own businesses, whatever they needed, because we need a lot, right? Like my little team of 4 is not at all capable of covering and supporting every single birthing family in our area. So more Indigenous doulas was really important. And again, this is an important part of reclaiming and rematriating and reclaiming those traditional birth practices. These are like socially distant, so that's why it looks, they're attended pretty well attended, but we had to be really separate. But this is the birth gown making class, a cradle board making class, so super fun. And then this picture up here was actually just taken a couple weeks ago when we hosted a oh gosh, I'm a new Dakota speaker, so Hok Chikiapi ceremony, so welcoming the spirit of the baby ceremony that we held for actually all of our pandemic babies. So all of our babies that were born with between 2020 and 2022 were invited to come to this ceremony so that we can welcome them into the community. And it was attended by about 20 of our families, which what isn't that bad. Like, that's a pretty good number. I was trying to think of how many babies were born during the pandemic. It's probably about half of the babies that were born during the pandemic attended. So it was really special for us to all be together and to welcome our babies into our community in a good way and have them introduced. And yeah, it was just a really special thing. And so that's something that we know that's really helpful. So thinking about outcomes and what role Indigenous doulas play in preventing maternal mortality, but we also have these additional outcomes, right, that are really important. So yeah, we have served 89 families in the last 3 years. So we launched our program in September of 2019 is when we started attending births and supporting families. So 100% of our families are identify as Native American, Pacific Islander, and Native Hawaiian. Like I said, about 85% are Native American, Alaska Native. And for us, that means the pregnant person needs to be the one to identify as Native American, Alaska Native, PI, or Native Hawaiian. I hope everyone understands kind of why that is, but I do get a fair amount of inquiries from non-Native birthing people who are partnered with Native family, a Native partner, wanting to work with us. And I do, 5-minute thank you. And I do have to turn them down. And the reason is because we're working on preventing death, and carrying a Native baby does not put a white mom at risk. And so that's something that we feel really strongly about, and we typically refer those families out to those other amazing Indigenous doulas that we help supported in training. 89% of our babies were delivered vaginally. Just for context, these other percentages are the King County average, or the King County numbers. So in King County, 73% of births are vaginal. So for us, we're just under 90%. So 89% of our babies are delivered vaginally. 90% of those births were unmedicated, which is huge. That's so huge. Where only about 32% of the general population delivers unmedicated. So we're really, really happy about that, and feel really strongly that doula support played a big role in a family achieving their goal of having an unmedicated birth. About 4% of our babies were delivered premature. So that's a birth before 37 weeks. And for Native families specifically, about 12% of our babies are born premature in King County. So again, a really great outcome there. Something that we did not expect is that 30% of our families choose out of hospital births. So we've attended a lot of home births and birth center births. And again, that wasn't an outcome that I set out from the get-go, but basically what happens is once we talk to families and let them know that they have the choice to deliver where they want to, and we will support them in finding a provider, that many of them choose out of hospital births because we consistently, our community generally feels very unsafe in hospitals. And so we're really happy that our low risk families are able to access it, other birthing spaces. And then 100% of our families have chosen to work with us postpartum for a minimum of 3 months, with about 5.5 months being average. So most of our families are working with us for, close to 6 months after they have their baby. And at that point, we start to discharge them. We do work with families pretty intensely the first couple weeks after they have their baby. So again, those first 40 days are really important to us. So we're in that family's home about 8 to 12 hours a day, 8 to 12 hours a week, that they're going to have doula support. So yeah, and a lot of our families work with us long term. So really happy about that. Okay, so here's my information. I'm sorry I like zoomed right through that, but I'm really grateful for everyone's time, but please feel free to reach out by phone or email. You can text me, whatever you got. So yeah, I don't know if we have time for questions or.
Thank you so much, Cami. That was really informative and really great. I want to make sure we build in a break to this. So we're kind of going through a little bit of some schedule shuffling right now. We're a little bit behind schedule. So Cami, if you could stay around for questions and things during our discussion session,
yeah, absolutely.
that will